My name is Joel A. Garcia. I'm a interventional cardiologist, an associate professor formerly at the University of Colorado, now at Orlando Health Medical Center and University of Florida at Gainesville. I was invited to the International Academy of Cardiology 2015 Congress, and I spoke about the clinical efficacy and safety of dual motion rotational coronary angiography when compared to standard coronary angiography. For years, we've been able to do a standard rotational coronary angiography that goes from a 55 to a 55 LAO to RAO angle, both in the cranial and caudal position for the left coronary artery and in the caudal position for the right coronary artery. For the most part, we have been able to prove the safety and efficacy of that traditional rotational coronary angiography since 2007. We have demonstrated a decrease in radiation exposure, contrast use, and in addition to that, a decrease in the total time for the procedure. For the most part, we thought to evaluate our ability to actually create a new model of dual motion rotational coronary angiography, where now, as opposed to just doing angles that are not broken into the cranial caudal angulation, they could be. This will allow for the imaging of the left coronary artery with one single rotation, and for the imaging of the right coronary artery with one single rotation as well. For that, we had three major limitations. The number one limitation was actually being able to break the craniality or caudality angle when it comes to the rotation as you're actively going from LAO to RAO or RAO to LAO. Once we were able to allow for the system to actually break that angle and do a single sweep from LAO to RAO while breaking the cranial caudal angle, we had another limitation, and that is to actually minimize the time in which that sweep can actually be completed. For the most part, the longer the sweep, the longer the coronary injection required. That brings me to one of the other limitations, was to prove that actually it is safe to deliver a longer coronary injection without increasing the risk of arrhythmia or the blood pressure and heart rate to the patient. We actually had a publication at Cardiac and Catheterization Interventions in which we proved the safety of a longer coronary injection during a 180-degree rotation for 7.4 seconds. That allowed us to actually be able to now minimize the risk of the injection itself. For the most part, those two limitations are now pretty much under control. And the third limitation is actually being able to find out what is the possible sweep that will cover LAO to RAO, cranial and caudal, that actually hits most of the hot spots that we need to see in the coronary anatomy itself. We sought to evaluate most of the 3D modeling archived cases we had at the University of Colorado in about 100 patients. This allowed for multiple arteries in which we evaluated the proximal, mid, and distal segments of the LAD diagonals, obtuse marginal circumflex, and right coronary artery. By doing that in each one of those patients and then doing it for all of the patients, we were able to create an optimal view map that minimizes foreshortening and overlap in the bulk of those individuals. And the question was, once you create that optimal view map and you minimize foreshortening and overlap for each one of those segments, what would the trajectory look like in LAO, RAO, caudal, and cranial that with a single sweep will cover most of those hotspots, both for the LCA and the RCA? That allowed us to create a trajectory that goes from left coronary artery to the right coronary artery, and what allows us is to actually image those arteries by doing one single sweep. The sweep for the left coronary artery starts in LAO cranial, goes by the PA cranial site into the RAO cranial one, goes down to RAO caudal, PA caudal, and eventually in LAO caudal. For the most part, the numbers under which it does that was actually objectively obtained by the optimal view map. We did the same for the right coronary artery, which looks like a reversed hockey stick. By being able to do that and minimize those limitations that we had in order to create this dual motion rotational coronary angiography, we now were able to evaluate its safety and efficacy. We measure the amount of contrast used in dual motion coronary angiography and compare that to standard coronary angiography, and we were able to reduce the contrast by 30%. The same percentage reduction was also seen in the dose area product or radiation exposure for the most part. In addition, the procedural time was not affected, and in fact, it is less for dual motion rotational coronary angiography than what it is for standard coronary angiography. Nonetheless, some time is required for the isocentering of the heart and some training is required. However, this is minimal and is easily surmountable by doing just a few cases. Now that the safety and efficacy of the dual motion rotational coronary angiography has been established, what we would like to see is the image content analysis and the screening ability of dual motion rotational coronary angiography when compared to standard coronary angiography. We asked 2 independent reviewers to actually evaluate those images and let us know how many of those 50% lesions, or in excess of 50% lesions, were obtained by evaluating standard coronary angiography versus dual motion rotational coronary angiography. For the most part, there was no significant difference and no statistical difference between the 2 groups. That allowed us to believe that when compared, the 2 groups were very similar in the ability of standard coronary angiography when compared to rotational coronary standard angiography and the other way around was pretty much similar. In addition, we thought to evaluate what the image content analysis also looks like for dual motion rotational coronary angiography, and presented a Likert score, L-I-K-E-R-T score, for the reviewer to actually be able to let us know what favors which type of imaging, whether it favors standard angiography or standard coronary angiography versus dual motion rotational coronary angiography on an independent review. It seems that there's, for both reviewers, there's a tendency to believe that dual motion rotational coronary angiography seems to be slightly superior than standard coronary angiography when it comes to the screening ability of the test. For the most part, we then conclude that dual motion rotational coronary angiography, when compared to standard coronary angiography, it is safe and effective, reduces contrast, radiation, and procedural time while delivering an imaging technology that allows for screening and image content analysis comparable to that of standard coronary angiography.